This is our great chance. He is the genius vascular and endovascular surgeon from Mumbai. He will speak on venous stenting. Just before the speech, I am request Mr. Sankalpo Vaspai from Boston Scientific Indian Hub. He will say few words regarding the product. Then we will go to the program directly. Mr. Sankalpo Vaspai, please utter some your speech.
Thank you, Dr. Mokbul. Good evening, everybody in Bangladesh, and good morning to Dr. Rahman in US. Good evening, Dr. Shekhar. It's a pleasure for us to be part of this program, and we really look forward to learning along with you. There are a few members of my team who are also on this call, and we take great pride in learning from the experts and passing on the learnings which we acquire in such sessions with the other physicians across the country. And we will not be interrupting, and please do allow us to listen in. I will not be talking about the products over here. We will let Dr. Shekhar talk about the venous interventions, and over to you, Dr. Shekhar.
Thank you. Now, Dr. Shekhar, he will deliver his speech over venous intervention tips and tricks. Please deliver your speech.
Sir, you already know that our program, the Today's program, is also live in Facebook pages. So you can watch it from Facebook and share it with your friends and family members. And there is a question and answer session after the keynote speech. So you can put up your questions here in chat boxes, Zoom application, or comment boxes in the Facebook. So I would like to request Dr. R. Shekhar sir to present his speech. Thank you. Dr. R. Shekhar sir.
Right, so I'll just get on and then. So good evening to our friends in Bangladesh, and good morning to Dr. Rahman in the US. Can you see my screen?
Yes, we can see.
Yes.
Okay, so great to be back with you people, and it's always very interesting sharing all our experiences with the surgeons of Bangladesh. So this evening we will be discussing a bit about iliac vein interventions. I'll share my experiences, not exactly the tricks, but a little bit of knowledge sharing. I'm sure most of you also are into this procedure. So it will be just basically sharing more than anything else. What we will discuss is, to start with, I'll discuss a little bit, I'll touch on the pathophysiology of the iliac vein lesions, right? Why we talk about it a little bit, what is the relevance of an iliac vein narrowing, and then the technical part of how to do the stenting, how to diagnose, and all that will be in the last part of the lecture. So we start with a little bit of pathophysiology, just a recapitulation of our knowledge. So I'll not be talking about acute deep vein thrombosis in this and how we manage the acute phase, but I'm also aware that a large section of physicians would be treating purely with anticoagulations and no interventions for proximal DVT. That had been the trend for many, many years in India as well, and continues to be a problem, a way of treating acute DVT in India even now. Now, what might happen if you just give anticoagulants and no interventions is done for a proximal DVT? Proximal meaning an iliofemoral DVT. What might be the problem if you just stick to that? For that, to have a proper answer, we need to look a little bit back into our mechanism of venous drainage. And if you can see this pictogram, you can see that this depicts the deep vein, and you can see as the calf pump compresses, right, blood goes in a unidirectional way upwards, doesn't return. And why it doesn't return is because of these beautifully created valves that nature has given us, these one-way valves. Now, this is what is the normal mechanics of venous drainage in a normal leg of a human being. Now, when we have a kind of a DVT, you'll find that the clots originally, they originate in these valves. So these valves are like shelves, and the clots actually start in these valves and then propagate upwards. Now, when we give only anticoagulants, what we are doing is not exactly dissolving the clots. We are merely preventing the clots from propagating, meaning that increasing in size. And what actually clears the clots is the body's own fibrinolytic system. So what happens is when the clots form on the walls of the vein, the body's fibrinolytic system comes into action. There is a degradation of the clot, and in the process, it sets up a kind of an inflammation. The inflammation is pretty efficient in many patients, not so efficient in certain individuals, and we don't know why. And in the process, what exactly happens is that very often the valves get damaged. So the clot gets cleared. So if you could recollect in your clinical experience, you get a DVT and you give only anticoagulants, 6 months, 8 months down the line, your duplex reports will say that there is no evidence of clots and there is complete recanalization. But in the process, very often you will find that there is a deep venous reflux because now these valves have got damaged. So that is one justification for at least in the for an intervention for clearing the clots. We will not touch upon that in this talk. Sometimes something else might happen. And what happens is that we all know that clots, when they start, are something like this jelly. But instead of getting totally recanalized, we may get what is called a cellular thrombus. So the thrombus gets infiltrated with inflammatory cells, and it organizes and forms a hard kind of a cement-like material, which causes a lot of inflammation, fibrosis, and eventually blocks of the vein. So what you get in 6 months' time is a obstructed outflow to the iliac vein. And in the long run, you land up with a patient. I'm sure all of you see these kinds of cases with severe pigmentation, venous ulcers, and the patient is generally miserable. Now, just to tell you how frequently you might see in your practice an obstructed iliac vein, I've just put an example of a case that we recently saw in our outpatient. Now, this gentleman is a 45-year-old male. He has a history of acute onset left leg swelling 3 years ago. He says he was treated with hospitalization, only anticoagulants, went home in 2 weeks, was on warfarin for the last 3 years, not particularly bothering about his INR or his drug interactions, his diet or anything. And then he comes to me saying that somebody has advised him, varicose veins laser for this kind of lesion, and he wants his veins out. Now, this is literally what you can see in the cartoon. It's a trap into which many unknowingly might fall. Because when we further investigated him, and I'm sure all of you must have come across this scenario, you find that on a venogram, the exit of the deep vein, that is the iliac vein, is totally blocked off, and there are multiple collaterals. Now, merely treating the varicose veins in that patient would not relieve him of his of his symptoms of leg swelling and pain, and would leave him as a frustrated person, and in addition would give a bad name to the varicose vein surgery, which is happening rampantly in our society in India. So the whole purpose of this discussion would be so that we are all aware that venous disease, venous ulcer doesn't mean a varicose. A venous ulcer doesn't mean a varicose ulcer. And whenever we are evaluating a venous ulcer, we have to keep at the back of our mind the typical history, which I will talk about briefly, and the fact that there is a possibility that there is a problem in the iliac vein. Now, why is there so much talk about iliac vein narrowing? So, why at all are we giving so much relevance to having a talk and discussing so much about it? Let us get a little bit back into our physics. And I'm sure all of you know Poiseuille's law. And the Poiseuille's law states that the vessel resistance to flow is directly proportional to the length of the vessel and the viscosity of the blood, and inversely proportional to the radius to the fourth power. So that is Poiseuille's law. Now, if you apply it to our obstructed venous tree, we can't do very much. We know that these venous ulcers and the symptoms of a venous ulcer are very often due to what we call a venous hypertension. So our job as vascular specialists is to seek a method by which we can reduce the pressure in the deep venous system or the resistance to flow. Now, there's nothing we can do about the length. We can give blood thinners and reduce the viscosity. But if you go back to Poiseuille's law, you see that if you can increase the radius twofold even, you're decreasing the resistance by 16-fold, right? So the whole principle of opening out an iliac vein to reduce a venous hypertension in the leg with the aim of healing a venous ulcer hinges on and is based on the principles of Poiseuille's law. So what is the typical situation where you would suspect that the iliac vein is blocked off? Typically, majority of patients we have seen with iliac vein obstruction or a narrowing come with a non-healing ulcer in the ankle, commonly but not necessarily in the left leg. The symptoms of chronic venous insufficiency or venous hypertension is very often disproportionate to the superficial reflux findings on color Doppler. So many of them actually come with a color Doppler test, and it shows that a very mild kind of superficial reflux is there, but it doesn't explain the severe signs of venous hypertension, venous insufficiency that you see when you do a clinical examination of the leg. Very often the patient gives a typical history that on prolonged standing, the leg swells up and there is a kind of a bursting pain. And more distressingly, since we are a tertiary referral center, very often the patients who land up with an iliac vein obstruction, which we diagnose eventually, have had multiple varicose vein surgery by various people. We have people who are very eager to put laser fibers into veins and treat everything as a varicose veins. So typically you might find these patients have already had varicose vein surgery, sometimes twice, thrice, 4 times. So that is the time when you get a patient like this, you should suspect possibly this patient has an iliac vein issue because of which his or her symptoms are troubling him or her. Now, these are the types of lesions that we see in our OPD. When you see a lot of pigmentation, lot of swelling, a nasty ulcer which is not showing any signs of healing, these are the cases where you would suspect that possibly there is a iliac vein which is the culprit for these ulcers and for these symptoms. So typically preliminary investigations, we all talk about CT venogram of the IVC, iliac veins. A lot has been spoken about MR venograms also as a diagnostic tool to pick up iliac veins lesions. But the pitfalls of a CT MRI are very often they are false positive and false negative. False positive means that your CT MRI says, yes, there is a problem in the iliac vein, whereas actually it isn't there. False negative is, it says everything is fine. There is no iliac vein lesion. The iliac vein is perfectly healthy, and actually there is a problem there. And that has been conclusively proved. I'll show you the data in my subsequent slides. The other thing is that it adds to the cost, and a large number of our patients have claustrophobia. So they're scared of getting into the MRI gantry. So these are the pitfalls of a CT MRI. And so what we do next is, when we suspect an iliac vein problem, we advise a patient an ascending venogram. Now, this is done usually under a local anesthesia. We keep an anesthetist as a standby because venous interventions can be quite painful. So we do keep a standby anesthesia backup. But generally, we do these under local anesthesia with sedation. And almost always the access that we have to the venous outflow is through the popliteal vein, with a patient either prone or in a frog leg position. Because why popliteal vein is that the common reason for an iliac vein treatment to close down or fail in short term or long term is a problem in the inflow. So we need to assess the entire inflow of the venous tree. So it's always preferable on a practical basis to access the venous tree through the popliteal vein. This is just to show you the bare essentials when you get into puncturing the popliteal vein. Of course, as I said, anesthetist always a must, but what we use is an ultrasound guide. And there are two ways to puncture the popliteal vein. Most patients would be comfortable lying down in the prone, as you can see here. It's quite easy to puncture the popliteal vein. Sometimes in obese patients, it might be difficult for them to lie prone, in which case you can do a supine access as well in a frog leg position. Once in a while, a jugular access is required, but most of the time we can manage with a popliteal access. You need to have in your cupboard sheaths of all sizes. We usually start off by doing an ascending venogram with a 5 French sheath. But if we propose to put in stents, then usually they require larger sheath size, say 8 French or 10 French. But we start off with a 5 French sheath. The other material that we use is for the diagnostic venous angiogram is a headhunter catheter, a 4 or a 5 French catheter, and a Terumo wire. So these are the basic, just the basic requirements for doing any kind of angiogram. We use that. And then once you do the angiogram, you might get a couple of scenarios. So I'll share with you two typical scenarios that we see. One is, you can see on your screen the two pictures, and you'll find that the blood flow up the leg is fine, but as you enter the pelvis, you find the iliac vein is all tattered. And then there is a host of collaterals which are going across to the opposite side. Now that is very often considered as the sign. In fact, I would go to the extent of saying that many people who are into interventions still believe that if there is no collateral, there is no obstruction. So the moment they see a collateral, they say, yeah, my diagnosis is right. There is an obstruction. That's why there are collaterals. Okay, so this is one scenario. You do a venogram and you might see the vein as it goes up, 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 and suddenly it is blocked here. And same thing here, it's blocked here. And then there are loads of collaterals crossing across the pelvis and trying to drain the vein from the opposite iliac system. This is one scenario. Now, this is another scenario. Now, one thing that one should get one's concepts clear when you're doing venous intervention is to get wrong concepts out of the mind. Now, just because there are no collaterals doesn't mean there is no obstructions. Just have a look carefully at these three pictures. On the left of your screen, it looks very obvious that there is a narrowing. In the central picture, you can see mild indentation narrowing at 2 points. So there's a double compression. And in the third picture, you're not very sure, is this normal or is it not normal? Is it just a spasm or what it is? So just for the record, let me tell you, in all three of these scenarios, the iliac vein is definitely obstructed and was definitely obstructed when we came to the next investigation. But, just because there are no collaterals, a large number of people who are into casual interventions say that there is no collateral, so this is not an obstruct. That's actually wrong. And I'll tell you why the concept is wrong from the data which I'll share. While we are talking about this and the double compression, let me just refresh your mind about Maithana syndrome. I'm sure all of you know about this Maithana syndrome. Now, Maithana syndrome can occur when the arterial tree compresses the venous tree like this. There are 4 sites at which it can be compressed. It's just not the Maithana, the left common iliac artery compressing the left common iliac vein. It can be at 2 sites, as you saw in the previous picture. Here, you can see at 2 sites it's compressed, right? It can be at this site, it can be at this site. So there are 4 areas. So, which is why I said that you might get a kind of iliac vein symptom of a venous ulcer due to an iliac vein compression, not necessarily commonly, but not necessarily on the left side. So you can get it on the right side as well, which we have seen in the past. And I'll show you a couple of cases where it's been on the right side as well. So we should keep this in mind, because these kinds of lesions very often predispose to precipitate a deep vein thrombosis, acute deep vein thrombosis. And unless you actually lyse the clot and clear the clot with an intervention, these lesions are very often not unmasked and are forgotten. So in the past, once we cleared the clot and we got a vein and we think about doing an ascending venogram and we suspect that is this narrowed, is this not narrowed? So how do we diagnose? So in the past, many of us, what we were doing was, we're doing what was called a crude balloon test. So we would put in a large balloon, say a 14 mm or a 16 mm balloon, and we would just dilate it at the lesion, right? And if we saw a waste, we'd say, wow, this is the classical picture of, say, a Maithana or whatever, or an iliac vein narrowing. It's a classical picture where you can see that as we inflate the balloon, there is a typical waste which is forming, and we would be convinced. But now we know that it's not necessary. Fine, you got a waste, you know it's blocked, but you can get a blockage without this kind of classical waste, which is why this is not exactly the ideal way to diagnose an iliac vein obstruction. So a little bit about why we should not stop at a venogram, only a venography. I'll show you. It's not an anecdotal thing which I'm telling you. There's lots of literature, and let's go back right to the 50s, where Cockett and his colleagues, they in the British Journal of Surgery in 65, you can see there's an article in which they have said that lesions are detectable on venography only in about 50% of cases, right? So the whole suspicion about iliac vein lesions was there in 1965 itself. A little bit more in the data literature search, we also know that when you have an obstruction, the venogram only gives you one aspect of it, right? So the compression might be 3-dimensional, it may be circumferential. Also, it's not necessary that it's a stenosis, that there needs to be collaterals. Sometimes due to an inflammation set off by an old deep vein thrombosis, you can get extensive transmural fibrosis of the entire iliac vein. And when there is transmural fibrosis, there is no scope for forming a kind of a collateral. So the whole vein is a fibrous tube, and that cannot be picked up actually clearly on merely doing an ascending venogram. This is more strong data from various experts on iliac vein, and just go through these figures. Data suggests that lesions are completely missed on venography, 25% of patients. The site of maximum stenosis is incorrect in 67% of cases. And the degree of stenosis is underestimated in 69% of cases. So these are all large data, large degree of, so it's quite obvious from these data that merely doing a venogram might not be the perfect way to treat your patients with iliac vein lesions. So then what is the next thing you do? Now the next thing we do, and we do it routinely now, and what is done worldwide, is what we call the IVUS, or the intravascular ultrasound. Now, couple of points regarding the IVUS. One, it's superior to venography because area metrics are important. So you need to know the actual area reduction before you decide on treating the lesion. IVUS guided stenting can be done under fluoroscopy in patients who have an issue with contrast. And it's much more accurate. I'll show you some of the pictures to tell you why it's more accurate. A little short video, I would request you to have a look, just for those of you who are not very familiar with the IVUS. This is the Boston IVUS that we use. And you can see there's a monitor there, and we're preparing the IVUS for use. And the catheter this is the catheter, you see, it's calibrated so that you can actually, as you withdraw, you can actually measure your lesion. So it's a calibrated, the blue thing which you see is the calibrated catheter. And then this is a video just to show you exactly, it goes over a 018 wire. And you see it's just a tiny catheter that goes inside through the popliteal vein. And with the help of that, you can map the entire iliac vein. It's pretty easy to learn. Initially, it can be a bit, the thought of it can be quite daunting, but I can assure you that we all started off thinking it's a very daunting thing, but now it's become a routine practice with us, especially surgeons. We very often have a mind block about ultrasound, but let me assure you that it's very user friendly and it's very easy to learn. And once you get an IVUS done, you can see beautifully how the compression can be delineated. It can exactly tell you where the compression is, what is the length of the compression, and the area reduction, all can be calculated and be on your screen. And so it helps you in many ways. The many ways are: one, once you've cleared the thrombus in an acute scenario, and you decide that you need to stent it or not, it helps to tell you whether there is residual thrombus, because we know if there is a residual thrombus in the iliac vein, we would defer a stenting. So IVUS 1 tells you when to stent, whether to stent or not. Secondly, it gives you beautiful images which tell you the dimension of the stents to be used. It tells you what is the upper limit of the stent should be, where the lower limit of the stent should be. And once you deploy it, you can beautifully evaluate. I'll show you a picture how you can beautifully evaluate post-stenting to give you a good feedback whether you've done a proper job or it needs a bit of touching up. The present negatives are, of course, where we live in a, both you and your country and our country, we live in a, cost sensitive society. And so it does add up a little bit to the cost. Accessibility and expertise is something which is evolving, and that is an issue, but it's a wonderful tool. The other thing about IVUS is just look at this history. Look at this lady, 79-year-old, with a champagne bottle leg, a huge ulcer that has been around for more than 15 years. She's had a spine surgery, history of leg swelling. Her Doppler shows that, there's a refluxing SFJ, GSV perforators, but somehow we feel that, something is not tallying why there is so much of severe pigmentation and fibrosis. So could this possibly be an iliac vein lesion, right? So we subjected her to an IVUS, right? And you can see these two images. Now to the eye, you could vouch for the fact that there is a narrowing not only here in the common femoral on one side, right? But also the iliac vein on the opposite side. Right, so you could really feel that probably this is a narrowing. Now that was the gut feeling, and we said we said that probably this patient is going to land up with stents or some kind of venoplasty. But when we did the IVUS, it showed clearly that there was no narrowing actually. It was just a kind of a spasm due to the force of the dye. And so by doing an IVUS, and this was the IVUS picture, it showed us that, what we felt was a narrowing was actually not a narrowing, and this saved the patient from an unnecessary stenting procedure. So IVUS actually not only helps you to diagnose what remains undiagnosed by an venogram, but also sometimes what looks obvious on a venogram is negative on an IVUS. So that is the real value and the beauty of using an IVUS for planning iliac vein lesions. Now coming to the stents that we need to put, a little bit about the technical aspects of the stents, right? These are some of the diameters that you see that are advocated for using stents. So when we use stents in the iliac vein, we use pretty large stents. Say a common iliac vein, we use usually 16 or 18 mm. As regards iliac vein, there was some skepticism initially about veins being a low flow system, whether these stents remain patent. But if you see these data from here, you can see that the patency rates are not really that bad when it comes to iliac vein, and it's improving with better stents and better understanding of the disease and better case selection. This data is improving even more now. The stents that we use are the wall stent. You can see it's a very robust, flexible stent, ideally designed for withstanding pressure from a fibrous iliac vein that we typically see in post-thrombotic iliac veins. And we use the Boston balloon because these are large balloons, these are large stents. So we need larger balloons, and we use this balloon to dilate the stent. The advantages of the wall stent that we use, which I showed you, are that it has good strength. As I said, it has all the sizes, it's flexible. You need good flexibility because we know that the veins need to accommodate, they are quite mobile and unlike the arteries, which are much more rigid. So you need flexibility. And it's probably one of the more economical stents that we see in the Indian market. So these are some of the pictures to show you how a venous outflow obstruction can be reconstructed using the wall stent, and then it can be checked with an IVUS. And then the newer concepts that are coming up, wall stents was what has stood the test of time, but with newer understanding of venous stenting, we are seeing the entry of dedicated venous stents, meaning that they have what you call an open cell structure. And you can see the Vichy stent, which is highlighted here, which is one of the very good stents that are available for use for venous stenting now. Regarding the question whether these stents have been studied or they're just new, there is good data regarding venous stents, and you can see the Werther study for the Vichy stent, which shows that it has a good 12-month patency rates and has been approved for use. These are some of the pictures I'd like to share with you, what a venous stenting looks like. So post reconstruction, you can see, like an arterial stenting, even a venous stenting, follows almost the same principles. So if you're into interventions, this should not be very challenging. And as you can see in this picture, this patient had obstruction at 4 places. So we had to do what is called a bilateral iliac vein stenting. And you can see here, post stenting, there is a good flow of contrast into the IVC. Now, this is one case which I showed you previously of obstruction. Now, one of the thrilling experiences one might talk about in iliac vein stenting is the disappearance of collaterals. So if you get a picture like this with all collaterals, and the moment you stent it, you will find that all the collaterals have disappeared. And when the collaterals which are present disappear, it tells you that probably you've done a good job and there is free unobstructed blood flowing into the IVC. Of course, I would always recommend that we confirm that with an IVUS, but this is a picture to just tell you how gratifying it is to see a picture with all the collaterals, disappearing following a successful iliac vein stenting. Post IVUS pictures, you can see it shows you a beautifully open stent and a wide patency. So this is one of the big advantages of using IVUS. Post stenting, you can be sure that you have done a good job. There is no narrowing anywhere, and there is a widely open iliac vein. On the question of when to stent, well, as far as iliac vein narrowing is considered for stenting, any narrowing more than 50%, or rather a 50% reduction in the area is considered significant for venous obstruction. It's a pathognomonic of a venous obstruction. And when you stent an iliac vein, especially if you're treating an acute DVT and you're thrombolized, you've cleared the clot, one should be sure there is no thrombus, residual thrombus. If there is a residual thrombus, then the data shows that patency rates significantly fall. So if you see residual thrombus and if you're not sure, possibly the best time to stent an iliac vein is maybe 3 months down the line when everything is clear and, possibly with anticoagulants, whatever residue you are worried about is either organized or clear. So that is the time. Otherwise, if you have an IVUS, nothing like it, you can go ahead, confirm right there and then that there is no residual thrombus in your iliac vein post lysis, and you can stent it right away. That's what we do in our practice. That's what we've been doing all these years. Post stenting anticoagulation, initially heparin for everyone. Thereafter, if it's non-thrombotic, all the patient requires is antiplatelets. We send the patient home on just aspirin. If it's post-thrombotic stenting, then we start patient on NOACs as well as antiplatelets. NOACs for the initial period of thrombosis, and then the patient long-term is put on antiplatelets. So as such, they don't require a full therapeutic anticoagulation after an iliac vein stenting. What is the kind of aftercare and surveillance that you need after you put in a stent in the iliac vein? We usually, our protocol is monthly color Doppler for 3 months. Then of course 6 monthly, but one should not forget that you still have an ulcer and you still have other issues in the leg like a weak calf pump. And so you need a good wound care and compression, calf pump strengthening, physiotherapy, all that adjunct is also required in addition to putting in a stent in the iliac vein. So that is in a nutshell about iliac vein stenting, and a little bit about pathophysiology, the clinical suspicion, and a little bit of technical details on the procedure itself and why IVUS is always preferable in doing these procedures. Thank you. And
thank you. Thank you, sir. Thank you, Ashokar sir. It was a great presentation regarding venous stenting. It is a new thing for Bangladesh, and we are really very eager to learn about this venous stenting. Now it's time for question and answer session. I would like to request Dr. J. Mokbul Hossain sir to conduct this question and answer session. Please put up your questions here, or you can raise your hand so that we can ask. We can give you a floor to ask the question. Thank you.
Definitely, this is an wonderful presentation by Dr. Shekhar. In Bangladesh, with the endovascular surgeons here have done a couple of cases and with a good result. But here we don't use the IVUS. But one gap, there is one gap. There is the presentation says without IVUS, there will be under evaluation of the lesion or sometimes over evaluation. So venous stenting is a new chapter, and where there is recurrent ulcer, where there is recurrence of the symptom, there is some sort of proximal lesion, and we should explore the lesion and treat with the help of a stent as well as with the use of IVUS. So now the forum is open for question and answer session. Dr. Shekhar, the IVAS catheter, that is 018 compatible catheter.
Yeah, it's
but 018 compatible. Is it possible to visualize iliac vein as well as the IVC with this catheter?
Yes, yes, very well. You can see everything almost. I mean, it's as good as it gets. You can see everything.
But IVC is a diameter that is 18 millimeter, 20 or more than that. Is it possible with this 018 wire to visualize the wall of the IVC?
Yeah, the wire is just for a support of the catheter. You know, as you would see in the video, the wire is, you know, the Boston Scientific IVAS catheter, what is called the OptiCross 18. It is loaded into the body, supported by the wire. The catheter tip is separate from the wire. It's what you call a rapid exchange. You know, it doesn't go over the wire right through the length, right? It is what you call a rapid exchange. So once it enters into the iliac vein, it is separate from the wire. It is just supported in part. Just the upper part is supported as the wire. So once the catheter is inside, it is independent of the wire. There is a chip at the tip, and that actually gives you good visualization of the entire IVC. It's as clear as it gets. You know, it requires a little bit of you know, initially it requires little bit of concept forming, because you know it's not a picture, it's not an angio, it's not what you call a endoscopic picture. You know, it's an ultrasound picture. So you need to get your spatial orientation right. You know, what lies where, and as you enter into the iliac vein, you know, you should have a spatial orientation initially, where you know that, you know, this is the point at which the artery crosses the vein, and as you come down the iliac vein, this is the point where the internal iliac actually crosses and the artery comes on one side, and you can see the artery actually indenting the vein as you pull it back. You know, it's a kind of pull back catheter. So you introduce it into the IVC, and then as you pull back, you know, you can actually see you can see your catheter coming down under fluoroscopy, and you can see the inside of the vein through your screen of the you know, through your ultrasound screen. So you can actually visualize as you pull it back. You can see from the IVC gradually coming into the iliac vein, and any kind of you know, you'll always see a mild indentation. You know, so you can actually appreciate it beautifully as the right common iliac artery crosses the vein. Even normally there is a mild indentation, which is normal. So you can even appreciate that normal indentation. You can see the artery separately, you can see the vein separately, and you can see the mild indentation. And as you cross the artery and come into the common iliac vein after the artery, you can see again that indentation is gone. Again, lower down, you can see the internal iliac artery crossing, and there is a mild indentation there. You can experience all of that. And the more you do, the better you get. You know, it's like any procedure. You know, once you get a spatial orientation, that is what is you know, is the what should I say? That is what exactly is the skill that you need to acquire: spatial orientation. That what is where on the ultrasound screen. You know, and once you get that, it takes probably 1 or 2 cases for you to realize, and maybe in another 4 or 5 cases, and it's after that it's just cakewalk. You know, it's as good as doing it as a routine procedure.
Doctor, thank you for a very nice presentation. I am Dr. Namul. I'm working in Nitur Hospital. This is the trauma hospital in Bangladesh. I have one question.
Yeah.
You mentioned that you omit CT venogram and MRV for false positivity. Yeah. Then your plan in all cases, that is the taking good history, then with non-healing ulcer, in the duplex you are getting the reflux, then you are straight going into the ascending venogram.
Yeah.
And at the same sitting, are you doing the stenting? Not like that in arterial case, we are doing the diagnostic. Then in the next time, you are just planning to, on the same sitting, always you do the stenting if needed. Is it?
Yeah, see, there are, I understand your question, where you are saying that first you do the diagnostic angiogram, and then in the second sitting, you do the stenting. Now,
Yeah.
The reason why that is done is basically where you have the luxury of patient coming to the hospital twice, right? Practically speaking, what we do is to make the patient come to the hospital only once. So when we suspect, we talk to the patient, we tell them, see, we suspect there is an iliac vein lesion. So we're going to do an ascending venogram and we're going to do an IVUS. If we see a lesion, we're going to stent it. So we take the consent and the entire, so it streamlines, everything gets done in one sitting. You have to, in the consenting, of course, patients are getting more and more, smart and internet savvy now. So many of them actually know a little bit about iliac vein and Maithana, they study things and come. So when they consent, we tell them we're going to do an ascending venogram. We're going to evaluate your iliac vein. We're going to do an IVUS. And on IVUS, if we find a narrowing, we are going to stent it. So everything gets done in one sitting. A patient doesn't have to come to hospital and get punctured twice. In single puncture, you can do everything. So it's a logistic thing. Insurance wise also, very many often patients, the insurance company says that, they question your repeated admissions. So it's not cost effective to have 2 admissions. It's more cost effective to do everything in one go.
No, thank
Can
you.
you use
Now we
C-arm in without doing in?
Sorry?
Hello.
Yeah.
Can you use C-arm in this procedure?
For your angiograms?
Yeah. This total procedure, angioplasty as well.
Yeah, certainly. See, when we all started off with C-arms. It's just that as we evolved as vascular surgeons, we had better access to technology, and we got better tools to handle. But C-arm is what, when we started off, we were doing ascending venograms, and we were using the balloon test. We saw waste, we were happy that there is a narrowing, but now in retrospect, I think a lot of cases that we said is normal we were just doing a venogram, seeing no collaterals, vein is normal, this is not due to iliac vein, and we are leaving it. Now in retrospect, and when we study data and with more understanding of the disease, more literature, more experience worldwide, we realized that a lot of patients who we have non-healing wound, and we did a venogram and we labeled it as normal iliac vein, possibly had a stenosis which we have missed, because we were thinking previously, that occlusion means it should be totally cut off, there should be collateral. If it is not there, this is a normal iliac vein. That is a wrong concept. And that is what we learned as we evolved as vascular surgeons. And we interacted more and more with the pioneers and the doyens of these procedures. We realized and learned that our concepts were wrong.
Okay, sir. We have 2 questions from our participants.
Yeah.
Dr. Jubair Ahmed, please put your questions here.
Thank you, Dr. Shekhar. I think it's definitely an outstanding presentation and definitely a new era in Bangladesh in venous stenting. Thanks again. So my question, I know IVUS definitely it's a best option, but in our country, the facility is not available yet, and also difficult to do an ascending venogram.
Yet available, facilities available. The Boston has managed catheter.
Sir, my question is, we are not doing routinely as ascending venogram. Before going to venogram, we need to diagnose first. So if we get the narrowing, then we go for ascending venogram with the procedure. This is my question.
Correct.
I am not saying that ascending venogram is not available. We going to the ascending venogram or planning to stenting same setting. But in Bangladesh, the financial issue definitely is a big issue. So what will be your more preferable between CT venogram and MR venogram? This is my question.
MR is probably more, if you have to choose between CT and MR, then an MR is possibly a more accurate tool to diagnose it. The thing is that, see, what we discuss in a meeting is what is ideal. In the real world, there will be there will be situations where you don't have access, you don't pay, you have access, but patient can't afford. So the whole purpose of discussing is that the first mental block that we have is that if we have a non-healing ulcer, we do a color Doppler and we see that there are some varicose veins here and there. We tend to first do the laser or do a Trendelenburg surgery and we finish it, and then the patient comes back, goes to somebody else, gets another surgery done, and the patient is miserable, and then the third guy or the fourth guy then finally gets to diagnose the iliac vein. So if we see a leg with a chronic ulcer, severely pigmented, your color Dopplers doesn't show that severe, reflux that tallies, you should think of iliac vein obstruction as one. That is the first mental block that we have to get out of. The next thing is to then, once you're thinking how to deal with it, right? So the whole purpose is that we, those who are not thinking about iliac vein should start thinking about iliac vein. Those who are thinking iliac vein should then start getting into, interventions for iliac vein. And then you have to sort out, what you call horses for courses. So what is suitable in your scenario, C-arm. If you don't have a DSA cath lab, we have a C-arm. Do a ascending venogram. If logistics tell you that a CT or MRI is more preferable as the first tool rather than jumping into an intervention, then so be it.
Yeah.
In that case, an MRI, but you should be aware that very often a CT MRI is bang normal, right? And then you are disappointed. Yeah. You should not let go of the patient saying, no, your CT MRI is normal, so your iliac vein is normal. That's not the case, right? Because very often you will find that actually there is an intramural fibrosis. So there are no collaterals. It's just a fibrous tube, which you can't appreciate on an MRI very often, right? So, and there is good data for that. So then you should know, and when we slowly evolve, when we started off our career, we are struggling with even getting an ultrasound done with a patient. Things are changing now. Slowly they will change. Technology comes in. Industry is supportive. Training facilities have improved now, right? So things will change. I mean, the first step is to get aware that there is something called an iliac vein, which is commonly an incriminating factor in a non-healing venous ulcer, which is often not thought of, right? So that is the first hurdle that you have to come across, that you have to cross.
Okay, thank you. And now Dr. Sadashanjan.
Sorry, this is, I think, Abid sir want to say something, and after Abid sir, I will ask some questions. Abid sir, please.
Dr. Shekhar,
yeah,
that's an excellent presentation, and you covered a lot of areas. I think it will be helpful for all Bangladesh vascular surgeons to think in terms that, chronic venous ulcer, which has been present for a few years, you right away need to think about central vein problem. May there be superficial veins or leg vein problem, but that's, even if you take care of that, that's not going to heal the ulcer. That's very true. Second thing, as far as the IVS is concerned, the diameter of the artery or the vein, what you see is the megahertz. That's the importance of the IVS. You look at it. If you are going into IVS evaluation of the venous system or the artery, the mega diameter, you need to have a bigger megahertz diameter, megahertz of the ultrasound. The guide wire doesn't make any difference. Some has 035 guide wire for support, and some has 014, and the peripheral artery 014 and 18. So that you have to remember. I know in context of Bangladesh, I know there's no IVS evaluated, but I also urge you guys to think about if the necessity of iliac vein interventions for the chronic venous ulcer or long-standing symptom of the leg veins for venous hypertension, you have to have IVS. All these other studies, MRV, pretty much screening. Ascending venography of no use to you because it's only 50%, at the best, 50% diagnostic. And on the basis of you can do the intervention. So you're missing other 50%. So if you're planning to do iliac interventions, venous iliac interventions, you have to have IVUS, no matter what kind it is. That's my bottom line advice. And otherwise you'll miss it. That does help you in 3 ways. One is to diagnose the disease properly. Second, it helps you immensely to diagnose the extent of disease, whether these compressions or the post-thrombotic syndrome. And also gives you the idea what size of the stents you need, what length of the stents you need to cover. And third thing is the post-interventions results. If you have a residual stenosis, the IVUS, it has not optimized the expected results, you can intervene with the higher pressure, bigger size balloon. So I can remember 20 years ago or 15 years ago when IVUS was not there, we used to have a tremendous struggle of diagnosing central vein. We knew there's a problem, but we didn't really appreciate the extent of disease, how bad it was at the central vein disease, iliac veins. So I think it's a must tool to manage the iliac vein disease. That's what you need to think forward.
Thank you, sir. Dr. Sadhya, please.
Thank you, Shekhar sir, for your excellent presentation. And I think you covered most of the basic things regarding iliac stenting. I want to know some questions. One thing, patient with varicose vein, present with C5 disease, we go routinely for iliac vein scanning?
No, I mean, if I understand your question rightly, routine varicose veins, you don't need to,
Patient with active ulcer, active ankle ulcer.
Yeah. So there again, if your history and your duplex findings are compelling, pointing towards a superficial system, right? And as I said, if the venous hypertension, when the superficial system is leaking, you may get an ulcer, but the kind of edema and severe pigmentation is not there. So if you have a leg where the pigmentation, the lipodermatosclerosis is severe with a lot of edema, right? Yes. That is when you will suspect. But I'm not suggesting for a moment that if you have a C6 varicose veins, you need to do an iliac vein evaluation. Right.
And another question, that is, as arterial stenting, we do always undersize. That is, perfect is the enemy for iliac artery stenting. But in case of iliac vein stenting, in an article published by Sri Shadri Raju, suggested that for 20 to 30% oversize.
Absolutely right. Stenting. Absolutely right. So, when we started doing venous stenting, we started putting in 12 mm stents, and a lot of them were occluding, and then as we started, getting better training, better literature, interacting with the experts, we realized that a lot of it has to do with the size of the stent. So in the common iliac, we commonly put 16 or 18. 18 is the common size that we use for an iliac vein. So the common iliac vein diameter is 16. We use an 18 mm stent for that. So you're perfectly right. You're absolutely spot on. You need to oversize.
Another question, that is, do you suggest that is gradual balloon dilatation or single balloon dilatation?
It doesn't really make any difference to the vein. The only thing is, one must realize that in venous interventions, balloon dilatation can be quite painful, unlike an arterial dilatation. So when you are stenting an iliac artery, patient very often just requires local anesthesia and sedation.
Yes.
When you're dilating an iliac vein, if your anesthetist is not knocking down your patient, the patient is going to scream. It's extremely painful because there's far more amount of fibrosis and there's far more amount of stretching that is going on. So, you need to have very often you need an anesthetist while doing these interventions. Also, as you correctly mentioned, you're going to oversize the stent. So it's going to cause a lot of pain. And many of these patients, the first 24 to 48 hours, they do suffer from backache. So you need to also tell the patient, very often we tell the patient in the pre-op itself that we're going to dilate. So it's going to be painful. So we're going to have an anesthetist. And post-procedure, when you go home 1 or 2 days, you will have some amount of backache.
So this dilatation, IVAS will help by measuring the area metric.
Correct. So,
Yes.
so that is the beauty of IVAS. It also tells you what size stent will be required.
Yes, sir. Another question, that is, do you in arterial stenting, we never try to cross in stent in common femoral artery, that is the joint area. In
Right.
case of venous stenting, do you suggest to cross the joint area?
Well, we do commonly cross, but the rule is one of the tips for venous stenting is that you don't cover the profunda. You can get into the common femoral vein, but stop short of the profunda vein. Right. So you can cross the joint. There is no issue with that. And commonly, in our part of the world, and I'm sure in Bangladesh also, the disease is quite severe because patients come very late. And you might have to give a good inflow, you might have to get into the common femoral vein, but you have to stop short of the profunda vein. The idea is you should not jail the profunda vein.
Another thing, that is, do you suggest balloon angioplasty or stenting in superficial femoral vein?
No.
I know it is contraindicated to do.
No. It has never worked, and
Yes.
I don't do it. Yeah, there are people who have done it routinely, but the results are, not great. So I don't. One of the criteria for doing the basic reason why stents fail in most of our cases is because the inflow closes down. So if you have severe disease in the common femoral vein, very often they are not the right candidate for doing an iliac vein intervention. So I would not advocate ballooning the common femoral vein. It doesn't work and it closes down.
One practical question, sir. Do you face any iliac vein perforation during your clinical practice?
Yes, one was there. In fact, I'm not sure whether we have this. We have a kind of a complication meet where I've also presented that. So if you do sufficient number of cases, you will have a complication once in a while.
Definitely.
We have had that where the the external iliac vein just ruptured, right? But
then sir, what should be the management of stent iliac vein?
Covered stent.
You need to see the basic rule in the cath lab is that when you do a vessel intervention, you should have a covered stent on the shelf at all times to bail you out, right? That is a basic safety thing which you need to follow. It's good to follow that because I've seen almost all the cath lab users in our hospital once in a while having this and the covered stent saving them. So you have to have a covered stent on the shelf.
Thank you, sir.
Yeah.
But the IBC diameter is sometimes more than 20, 24. And the maximum size of a covered stent is 13.5. Then if there is leakage in the IBC, then how will you cover it?
Well, usually by the time the flow comes to the IVC, the pressure is very low, right? So most of these IVC, they don't rupture and just flood the abdomen. It's a kind of a minor tear, probably just a balloon tamponade, or even just wait and watch. It stops. Usually there is by the time the blood reaches the IVC, the pressure is very low. So unlike a aortic rupture, the IVC tear during balloon doesn't give rise to that torrential bleed or a huge hematoma.
But can we put thoracic endograft to seal the IVC?
You need to have it on the shelf, but generally you don't order for a thoracic endograft when you're doing a venous intervention.
And may I ask another question, please, sir?
Yeah.
That is regarding instant restenosis of iliac vein stenting.
Yeah.
Do you practice only balloon angioplasty or stent within the stent?
No, generally we just do balloon angioplasty.
With drug-eluting balloon or plain balloon?
No, we don't use drug-eluting balloon.
Yeah, plain balloon, come
because
on.
you see, you don't get that size of drug-eluting balloon. You know, the iliac vein, which are narrow, they are 12 or 14, 16. You don't get drug-eluting balloons. At least in India, we don't get drug-eluting balloons of that size.
There's none anywhere else either.
Yeah.
But when the stent is crossing the inguinal ligament, there is any chance of stent fracture?
No, actually, I don't think that is a big issue. The current lot of stents are very robust. They don't fracture because you're just going a little bit into the common femoral vein. That's all. So, you know.
The venous stent is designed for not fracturing, and that's the whole purpose of that. The fracture rate of the venous stent is lot less than the arterial stent, and the flow pattern, and then there's no robust pressure in the vein as in the artery. So those two things makes a whole lot of difference.
But you are telling about the size of the common iliac vein stent 18. But if the question of iliocaval kissing stent, then the 18 and 18, the 36 millimeter will be the IVC. Is it the oversize of the?
No, if you're doing kissing stents, then we put smaller bilateral.
A smaller bilateral. What is the size?
So we put 14, 16 is quite okay. The vein, the IVC is quite accommodative. Unlike the artery, it doesn't get squeezed. The vein can be, the IVC nature itself is that with it has this good kind of phasicity. So with various phases of respiration, IVC can be flat or it can be hugely ballooned. So putting two stents inside the vein, inside the IVC, doesn't really cause that kind of squeeze that you see in an aorta. The aortoiliac things, if you put two large stents, they squeeze each other because the artery is a much more muscular tube. The vein accommodates a lot more space. So we put two 14s or two 16s we have put. I don't think it should be a problem.
Is there any chance of a stent migration towards heart, and then what is the answer?
Well, literature has shown it, but I've never luckily had this kind of problem.
This is
pressure in the vein. The pressure in the vein is very low, so it doesn't get pushed up like that, right?
Sir, another last question, sir. It's from Dr. Swadesh. In last EVL in Delhi, Amresh Sattaki sir present a case that is common femoral vein is cicatrized, and he did the case as a hybrid approach. Do you suggest opening of the common femoral vein?
Endovenectomy. So sometimes
endovenectomy followed by venous stenting.
Yeah, so that is one thing which can be done. So if you don't have a good inflow,
yes, sir,
right, but the number of cases who are suitable for that are very small, because it's very rare to have the common femoral vein and the profunda, all healthy, and just the little bit of endovenectomy. When you do an endovenectomy, it's just the common femoral vein which you open. So it's very rare for having just the common femoral vein cicatrized where the superficial femoral vein is healthy. So, the number of cases you will get to have that kind of thing, probably in a workshop, you search the whole year and you get one case to do, but routinely, hardly you will get a case suitable for that kind of procedure. It's good to know it, as surgeons, it's good to know it and good to do it, but to actually get cases suitable for that, it's difficult.
That also depends on the patient condition. If you have already did the interventions in the iliac vein and you still have a high grade or recurrent stenosis of the common femoral vein, then you may consider that. Otherwise, it doesn't come routinely. It's a selective patients.
Yeah.
Boston has got all stent as well as the VC venous stent. What is the difference between the two?
Well, venous stents, the whole concept has come one, there are two reasons why the venous stents are coming in for, there are two reasons. One is that this is open cell, right? So you will find, unlike a, dense net, the cells are open, right? So since when it's deployed, the cells open out. So one of the issues with putting a stent, venous stent for a Maithana is there is always a danger of occluding the opposite iliac vein, right? Unless you have a damn precise kind of placement, which is very often impossible, right? So you do need to put a little bit of stent into the IVC, and in doing so, you might occlude the opposite iliac vein mouth. Now, initially, the thought was that nothing happens, right? The vein is very forgiving. But then in the last couple of years, you will see in the literature also, there are lots of papers published of contralateral DVT due to opposite side stent occluding the outflow, right? So that, taking in mind that, the venous stents overcome that problem, the regular stents, the arterial stents or the stents which were previously used, they are the closed cell, thickly, thick matrix kind of thing. So there is a risk of occluding. The open cell ones allow the inflow of blood from the contralateral iliac vein also. So that is the whole concept of iliac vein, the venous stents.
And
the other couple of difference between those two is it's very difficult to deploy all wall stent precisely.
Yeah.
And the foreshortens. The Vinci does. And as you mentioned, the other difference is the proximal distal end of the wall stent is weakest point of the whole stents. So you remember those flares up a little bit at the end. That's why it's weak. So if you have it in the vena cava, they will flare up on the opposite vein, right common femoral vein. That's the reason it causes the thrombosis of the right iliac vein.
Yeah.
So those are the few little difference between the wall stent and Vinci. And then most of the venous stent you can deploy precisely wherever you want and whatever the length. There's no foreshortening. Exactly the length you measured on the IVES. Say you need a 90 millimeter length, you have a 90 millimeter length, then you'll cover the 90 millimeter lengths. There's no foreshortening. So those are the difference between the wall stent and other venous stents.
And one thing, when there is post-thrombotic syndrome, there is combination of antiplatelet plus anticoagulant. Then if there is dual antiplatelet, then what will be the dose of anticoagulant? What will be the dose of NOACs?
Well, dual antiplatelet plus a NOAC, the incidence of bleeding is higher.
So
we knock off. Normally, we withdraw the clopidogrel and put the patient on a regular NOAC dose as indicated for a DVT, right? So if the DVT NOAC dose is 15 milligrams, say, of rivaroxaban for 3 weeks and then 20 for 3 months, continue that till 3 months. Thereafter, we withdraw the rivaroxaban and continue with the ecosprin. And we generally go with 150 once daily.
Okay, but not the antiplatelet and NOACs simultaneously.
Not dual. No. Antiplatelet, single antiplatelet, yes, but not dual. Not dual.
Which one? Anyone?
Clopidogrel we withdraw usually. The Plavix, yeah.
Aspirin and say for rivaroxaban.
Rivaroxaban, yeah.
Usual dose.
Yeah.
Sir, aspirin later on how long?
Lifelong.
Lifelong, yes.
Yeah.
And another thing, do you use Venogram stent from BD in India, sir?
We've used all.
Okay.
Yeah, we've used everything. Everything.
There are other Venovo and the adhere has a variety of size and diameter. I think the Venovo and the adhere goes up to 20. The Vinci and the Zilber goes up to 16. And then a more variety of choices on the venous stent on those two brands.
Most
Venovo,
of the time, correct.
Pardon?
Most of the time, what is used is decided on the availability of that size at that particular moment.
I understand. I
Yeah,
understand.
yeah,
You can have it available in the store all the time. So
Yeah.
all sizes.
Yeah.
But the Venovo and the adhere gives you more flexibility of the size and the length. And I think the Zilber goes to 7 French sheet, and rest of the needs 9 or 10 sheet.
Yes, sir,
So
but
those are the few
the
subtle
Zilver is not available in India.
I see.
Yeah, yeah.
Jia,
Sir.
already 11.
Yeah, thank you, sir. And thank you. It was a nice discussion, especially very informative discussion. And there was lots of questions from the participants that it actually reflects that we want to learn this from our learned mentors and teachers and speakers from different areas. Now, I would like to request our national faculty, Professor Dr. Noresh Chandra Mondal, head of the department, vascular surgery from National Institute of Cardiovascular Disease, to say something about today's program. Sir, are you there? Yes, please.
I am audible.
Yes,
I
sir,
am
yes,
audible.
you are audible. Yes,
I'm audible.
Thank you, Dr. Shekhar, for your nice and brilliant presentation. So many things are discussed here. We learn many things. One thing that we get many patients swelling of the leg with venous ulcer, but in duplex study we get only occluded common femoral vein due to drug abuser, and this common femoral vein could not be seen. There is a fibrosis and there is no sign of the vein. What is the management in this type of disease?
Probably substitute that segment. If it's just a short segment, probably the best way to do is to substitute with a suitable conduit. To substitute, yeah, with a suitable conduit. Yeah. Most of these will probably just be a localized fibrosis. It's going to be a localized fibrosis. Yeah. So best is for these, probably an open surgery is always a better option to an endovascular.
Right.
Yeah.
Thanks.
Yeah.
Thank you, Dr.
Thank you, Professor Dr. Noresh Chandra Mondal, sir.
I do have a quick comment on that.
Yes, sure.
Sorry, the substitute will be make a tube out of the saphenous vein or short saphenous vein, preferably. You may harvest it out and slice it out and make a short tube for appropriate diameter of the femoral vein. That's the best substitute. Yeah. The other substitute is available in the United States, like a cadaveric vein and cadaveric autogenous, even arterial part. But in Bangladesh setting or subcontinent setting, harvesting in saphenous vein from short saphenous vein or cephalic vein, make a tube out of that and then replace that segment.
Thank you, sir.
And now I would like to request Dr. R. Shekhar, sir, from Pupliteal and Dhirubhai Ambani Hospital to say something about today's program. Thank you.
I think it's been a great discussion. As always, it's a pleasure actually not only talking to all of you, but also to know that there is so much of there are so many common issues between both your set of patients and our set of patients. I think this is really satisfying for me for sharing my inputs into that, and hearing your issues is really very stimulating. I'm sure that in the near future we will have more time to interact. Maybe once this COVID thing is over, we could even have a kind of a session where we could do all these procedures together and share our knowledge. Thank you for having me.
Thank you, sir. Yes, inshallah, someday we'll meet and we'll talk about this again. And now I'd like to request our beloved mentor, our international faculty, Dr. Abdul Rahman sir, to say something about today's program. Please.
Well, thank you for having me, and thanks to Dr. Shekhar for providing some info and the time to educate this young group of physicians in Bangladesh. And as I said, this is stimulating for me as well. As you know, has been stimulating for me all these years, and I still enjoy discussing things with you guys. The venous issue and the lymphatic issues has been a area in Bangladesh which hasn't been really draw attention to the physicians in general, not to talk about treating them. So if you guys can show to the other fellow physicians that yeah, there is a remedies available, you'll see a lot more patients in the venous problem than the arterial problem, and that really hampers the everyday's activities for those group of patients. Arterial patients and older, they're what do you call, have already limited multifactorial disease. They're not that active. They're not contributing to the society as much as the younger people do. I think you need to keep that in mind. And that is a very important part for the national contributions. If you can favor those guys, make them active and functional, that is a great contribution to this society.
Thank you, sir. Thank you, sir. It was really inspiring for us. Now it's time to close our today's session, and also to express vote of thanks to the participants and also to Dr. Arshagar sir and our scientific partner, Boston Scientific. So I would like to request now Dr. J. Mokbul Hossain sir, vascular and endovascular surgeon from Besida Hospital, to say something and close the session for today. Dr. J. Mokbul Hossain sir, please.
Thank you all. We enjoyed the program definitely. And one thing we learned from this session, when there is venous ulcer, we should think about the iliac vein stress. And to solve the iliac vein lesion, we need different size venous stent. Not only the stent, we also need IVAS. These two combination, and with technology, we can help this group of patients. So with these few words and thanking you again, today's webinar is the close. Thank you all.
Thank you.
Thank you, sir.
And good night.
Thank you, Dr. Arshagar sir. Thank you, Abdul Rahman sir.
Thank you, Dr. Shekhar.
Thank you.
Bye-bye.
Assalamu alaikum to all.
Bye-bye.
Walaikum assalam, sir.